is why do I think even in lumbar degenerative pathology, we need to create lordosis, especially at L4 to S1? My disclosures again, and fundamentally, we recognize now since 2005 that our sagittal alignment parameters are related to health-related quality of life. And pathology that are associated with postoperative malalignment includes adjacent segment degeneration, junctional pathology, and mechanical failures of our constructs when we don't create lordosis. And I'll show you some examples of failure to recreate lordosis and why that has a consequence. So the story really begins with alignment back in 2005, where the underlying hypothesis here is which measurements matter. So we created this radiographic measurement manual for deformity. And quite honestly, the hypothesis going into this was going to be, we thought that lumbar curves and rotational subluxation and olisthesis were the parameters that mattered. And it turned out that the parameter that had the highest correlation with health status was sagittal, global alignment. And it wasn't a great metrics. It was a C7 SVA that we used, and that had the highest correlation with health status. Subsequently, I think the work of Frank Schwab and Virginie Lafage identified that looking at the pelvis was also important. So there were better correlations with pelvic tilt and lumbar pelvic mismatch. What I want to point out is that these were all impact-based parameters. So these parameters, when they were off, had an impact on health-related quality of life. These were also derived from people who were in malalignment, patients with deformity and patients with symptoms. When we look at the shape of the spine, and this is an older paper that Mark Bernhardt and Keith Bridwell wrote, in the shape of the spine, I think looking at normal parameters is important. And even as early as 1986 or 1989,